Hi, my name's Gemma Glover and I'm from the Enhanced Care Home team, and today I'll be talking to you about end-of-life care in the care home setting. The aim of this presentation is to build on the knowledge care home staff already have around end-of-life care, to increase confidence around providing end-of-life care in the care home setting, to understand how to use a person-centred approach to care at end of life, to understand how to support families. Healthcare professionals tend to use a lot of jargon around palliative care. Palliative is a term used to describe an illness that someone is suffering from that has no cure. However, the person may live for a long time with the disease. End-of-life care is support for people who are in the last months or years of life. End-of-life care should help a person to live as well as possible until they die. A person can receive end-of-life care in their own home, in hospital, in a care home or in a hospice. People providing end-of-life care should take a person's wishes and preferences into account and support those who are important to the individual. This has been taken from the NHS website. The terminal phase describes the last hours or days of a person's life. This is when someone is actively dying. It can be difficult to recognise that a person is in the terminal phase of life, but it is essential so that we can provide appropriate care to the dying person. So, how do we recognise that people may be entering this phase of their life? You may notice that the person is deteriorating rapidly or more gradually. Sometimes this can be day to day or hour to hour. The person can have reduced mobility and become increasingly weak and tired without any cause. For example, an illness which could be reversed, which we will come on to shortly. They may express a realisation that they are dying. The person may have reduced cognition, ability to communicate and social withdrawal. They may have a reduced level of consciousness. They may become delirious or agitated or be bedbound. They may have a reduced intake of food and fluid. They may have cold extremities, so hands and feet, and have mottled skin. They may have an altered breathing pattern, and this can range from shallow, rapid breathing to slower breaths, where a person appears to be taking long breaks between some breaths. For more information on the deteriorating resident, you may want to refer to the FREED tool. The FREED pathway is focused on improving early recognition of frailty, end-of-life planning, a response to the deteriorating person, utilising news to and effective escalation of clinical pathways. Each resident should have a fully completed resident information sheet that is updated regularly, dependent on the resident's condition. The aim of the pathway is to use the appropriate tools to ensure appropriate planning is in place to prevent inappropriate admissions to hospital. The Gold Standards Framework, GSF, is a framework used by many GP practices, care homes and hospitals to enable early recognition of patients with life-limiting conditions, helping them to plan ahead to live as well as possible right to the end. For more information, please click on the link. It is important to recognise that there may be reversible causes for some signs and symptoms that we have just described on the deteriorating resident slide. An acute change or decline in a person's condition could indicate an illness that can be reversed, such as infection or dehydration. It is always important to escalate signs and symptoms to the appropriate professional. For example, if a resident is eating and drinking less, you should refer to GP, Dudley Clinical Hub or dietitian unless it is clear that the person is in the terminal phase of life. If they are struggling to swallow, you should refer to the speech and language team. For signs of infection, please escalate to Dudley Clinical Hub for input unless there is a clear escalation plan in place, preferably a respect process, which you can then follow with any other ACP documentation. The respect process creates personalised recommendations for a person's clinical care and treatment in a future emergency in which they are unable to make or express choices. Dudley is introducing the respect process. A respect process is a discussion between a person and/or their family and a healthcare professional. It is followed by a piece of documentation that describes a person's medical condition, escalation plan and cardiac resuscitation status. It forms a clinical part of a person's advanced care plan and should be completed with the resident, if possible, or their legal power of attorney. Where a legal power of attorney has not been appointed and where the resident has lost mental capacity to make decisions about their health and well-being, a best interest decision must be made on their behalf. For more information on respect, please either look out for online training via the Dudley Hub page or contact the Enhanced Care Home team for an information pack and support. Advanced care planning is the term used to describe the conversation between people, their families and carers, and those looking after them about their future wishes and priorities for care. That quote is taken from the Gold Standards framework. Some care homes have their own ACP documentation, which they use to aid discussion and documentation of a resident's end-of-life wishes and preferences. If you do not have a documentation template that you already use, you can access the Planning Your Future Care document on the Dudley Hub. This is a document called Priorities for Care of the Dying Person, and it's used by Dudley Trust for those in the terminal phase of life. This is the Priorities for Carer End of Life model, taken from NICE guidelines. We should be recognising that someone is dying. A person whose condition has deteriorated should be escalated to an AMP or GP to investigate and assess whether or not there is a reversible cause to treat. We should then communicate sensitively with them and others important to them. Talk sensitively with the resident and their loved ones and inform them of what is happening. Listen to concerns and reassure where you are able. Escalate concerns that you cannot answer to the appropriate healthcare professional. Involve. If a robust ACP has been written, you can discuss and follow plans with the involvement of the resident and/or their loved ones. Discuss any treatments and care given, such as symptom control, and listen to what is most important to the individual. Support. Discuss and assess the needs of the dying person's family. Encourage open visiting so that they can spend time with their loved one and include them in providing care if they wish. Plan and do. Ensure that a person-centred care plan is created involving the person and their loved ones. This should have a holistic approach to meet the person's physical, emotional, psychological, cultural and spiritual needs. It is important to maintain oral hygiene at the end of someone's life. Some medication can cause a dry mouth and can be very uncomfortable. A GP or AMP can prescribe artificial saliva sprays for the dying person to aid comfort. If a person has periods where they are alert, they may ask for their favourite drink. Ensure that you refer to speech and language therapy team or SALT. If appropriate, they will use a feed at risk form with guidance for the individual. Remember to use a person's favourite drink to give mouth care if you can, using a small soft bristled toothbrush or an oral care brush. In the last phase of life, your resident may be unconscious, and this can be a cause for distress or panic. As long as all reversible causes have been explored and there has been clear communication with the medical officer, the person and those who are important to them, and an escalation plan is in place, This is a normal part of the last phase of life. Important things to consider are that you reassure the family that a person's hearing and sense of touch are the last senses to diminish at the end of their life. Encourage loved ones to talk to the person and involve them as much as possible. Consider putting on the person's favourite music, TV programme, film, or reading to them. It is important to look after a person's pressure areas at the end of life. Ensure that appropriate equipment is in place for the person and turn as clinically appropriate, considering a person-centred approach. Discuss the risks of skin breakdown with loved ones and clinicians and weigh this up carefully with the person's comfort. Use an MDT approach to writing a person-centred care plan which meets the individual's needs and preferences. For example, you may need to ask for pain relief to be given before turning if your resident struggles with pain. Encourage open visiting, and should loved ones be accepting, reassure them that they are welcome to hold vigil at the bedside. Families may ask you how long you think their loved one may have to live. The truth is that that's impossible to say exactly. We usually talk in broader terms such as hours to days, days to weeks, or weeks to months, for example. We can reassure loved ones that while we cannot give an accurate prognosis, we will support them and their loved one during this time, and we can refer to the GP or the clinical hub for further support if required. Families may want to be involved in some of the care given to the dying person. Discuss with them which parts of care they may want to become involved with, and try to glean whether this is something the dying person would approve of. You may already have this information in the resident's ACP. For example, family may want to give mouth care, and you can assess if this is safe by explaining the process to them, and possibly helping them to do this for the first time if they are unsure. Explain how symptoms are being treated and how other teams are supporting all of you to achieve the best possible outcome for the resident. For example, are the end-of-life rapid response team involved in care? Explain their role and the input they are having with the dying person. After a person's death, a qualified professional needs to come and verify the death. Ensure that loved ones are given time. There is no rush to leave. Know who the chosen funeral director is, and ensure the person who has died is clean and tidy. Refer to advanced care planning for specific instructions for after death. Supporting families. Be kind and sincere. Ensure that they know how much you care for their loved one and that you understand how important this time is. Take the time to do the little things that are important. Ensure family have access to drinks and food if you are able. Listen. We don't have to have the answers. Be honest if you need to go away and find out an answer to a query. We don't always need to fix it. Sometimes family just need us to listen to them. Support. Ensure that information on changes to a person's condition or treatment is communicated effectively, and that when you are faced with a challenge that you are able to regularly update family on the actions you are taking. Practical needs. Ensure symptom control is managed by contacting the hub or GP to access the right service for the resident. Emotional needs. Show empathy and support for how emotional people will feel at this time. If deterioration is rapid, there may be shock or anger. There are strategies for dealing with this, and it's never about the staff. It is about the situation and about grief more than anything. Reassure people that it's okay to feel whatever they are feeling, and while we cannot change the situation, we can support them and we are here for them. Spiritual needs. Please don't confuse this with religion or faith. While your resident may well have a belief which means they would like a faith leader involved in their care, they may just have key aspects to their life which are important to them. It might be playing with their grandchildren or being in nature. Use a person-centred approach and think about how the person who is dying has lived so far. Can we incorporate any aspects of this into their care now? Is there information in their ACP that can help you? Nice touches for supporting families after death is if a representative from your home can attend the funeral and send sympathy cards to the family. Caring for people when they are dying is a great privilege, but it can be stressful and taxing on our emotions. When we care for people for a longer period of time, the loss can feel more intense. If there have been challenges in delivering care at end of life, it can leave you feeling upset. It can be helpful to reflect on the care you gave with colleagues and support one another. If you feel you are struggling emotionally and psychologically, there are services which can help you within Dudley. Please click on the link for more information. Finally, may I take this opportunity to thank you for taking part in this presentation. Please remember to escalate all clinical concerns for your residents to the Dudley Clinical Hub. Thank you.